The next witness in our case is Dr. Valerie McLaughlin from the University of Michigan.
So I'd like to call to the stand my esteemed witness, Dr. Val McLaughlin from Michigan. So Val, you are an esteemed researcher in pulmonary hypertension. You've also done a fair amount in this area of CTEPH, is that correct?
That is correct.
And how many patients with CTEPH would you say that you've treated over your career?
Over my career? Oh, hundreds.
And you're very aware of all these different clinical trials and the little nuances, is that right?
Yes, sir.
Okay, so let's go back, because I wasn't really satisfied with Dr. Forfia's witness in terms of explaining the clinical trial. Could we go back to CHEST 1 and specifically talk about the two different patient populations that were looked at and what those outcomes look like?
Sure. So CHEST 1, which was a very important clinical trial of riociguat in chronic thromboembolic disease, looked at patients who had either surgically inaccessible disease, and these patients had their pulmonary angiograms reviewed by a panel of expert surgeons, and they all agreed that it was surgically inaccessible. So that's one group. And then the second group were patients that continued to have pulmonary hypertension after an endarterectomy. So in a way, these patients already received some very aggressive therapy for their pulmonary hypertension, and as is sometimes the case, despite taking out as much clot burden that could be reached during surgery, they still had some pulmonary hypertension, be it from small vessel disease or from distal clot that was not retrievable at the time of their surgery. And in that trial, those two groups were really lumped together in the overall trial. That was how it was designed. And it is indeed true that the patients who had inoperable disease had a better improvement in their 6-minute hall walk than the patients who had persistent pulmonary hypertension. They both had improvements. The effect was just blunted in patients who, in actuality, had already received some treatment for their chronic thromboembolic disease. In addition to the primary endpoint of 6-minute hall walk, there were also improvements in both groups of pulmonary vascular resistance and biomarkers such as NT-proBNP.
Was the difference in 6-minute walk statistically significant for the group of patients who had undergone PTE?
So the patients who had already undergone PTE had a blunted treatment effect. It was about 26 meters as opposed to 54 meters, and the confidence interval crossed the line of unity.
So it did not, is that correct? Yes or no?
In the subgroup analysis, it was not statistically significant.
And was the magnitude of benefit as far as PVR, we talked about 6-minute walk, for PVR and NT-proBNP, was it also similar, or was there also some suggestion that it might be a lessened benefit?
Same direction, but blunted treatment effect.
Could you also talk to the clinical events that were seen in the CHEST 1 trial? What did we see in terms of clinical events and the effect of riociguat on those events?
Yeah, sure. So one of the secondary endpoints of the CHEST trial was time to clinical worsening, which is a composite endpoint of a number of events. And over the course of that 16-week trial, there were really very few events in the essentially pre-treated patients, in those patients who had already undergone a pulmonary endarterectomy and went into the trial with post-surgical pulmonary hypertension. Really minimal events in that group compared to the group that came in with inoperable disease.
So would you then assess this as it appeared from this at least, the post-surgical group had a pretty low event rate during this follow-up?
The post-surgical group, the patients who had already received a very important therapy for their CTEPH, had a lower event rate during that trial, correct?
So in fact, how many events were there in the group that were treated medically?
There was only one clinical worsening event.
And that was in the person treated medically. In the group that got placebo?
There were none.
So very low, and again, I want to focus and focus the attention of the jury on this, that this is a group of patients that we're discussing, should we be treating them or not, and in fact, the ones that weren't treated in this study had no clinical events.
That's correct.
Now, how would you interpret the current treatment algorithm? Do you think the BPA patients post-intervention, should we recommend medical therapy for that group?
So I think there's an absence of data in this group. I think everyone is very excited about BPA. We are happy to offer another treatment option for our patients who do not have surgically accessible disease. And I think particularly in the US, our experience with BPA is growing. I'm hopeful that it will provide a good treatment options for our patients, but I think there's a lack of data to make any conclusions about medical therapy in this setting.
Could you maybe just summarize for us a little bit the differences between the patients that get treated, and we've talked about this a little bit, the patients that get treated surgically versus the ones that we discuss treating with BPA?
Sure. So I think, as already been alluded to, the treatment of CTEPH really requires a multidisciplinary team. We have conferences where we discuss patients that include a PEA surgeon, the pulmonary hypertension experts, interventional cardiologists, interventional radiologists, sometimes hematologists. So we all really have to sit down and talk about what's the best thing for each individual patient, because this is a complex disease and the patients are different. In terms of making that first decision, and the first decision is whether or not the patient is a surgical candidate, in addition to some of the comorbid illnesses that Dr. Sagar reviewed, really it comes down to the anatomy. What does the pulmonary angiogram look like? Where is the chronic thromboembolic material? And in the hands of that surgeon, is it surgically accessible? And if it is, in the absence of the other contraindications that were reviewed, the very strong recommendation for that patient is surgery. If a patient does not have disease that is surgically accessible, then they can be considered for balloon pulmonary angioplasty. And this is a growing field in our country. There's some experience with it in Japan, some in Europe, and over the past couple of years, we're starting to gain experience with this in the US.
Do you think the people that have residual pulmonary hypertension with either of these interventions, are they pathologically similar, pathologically different? Is it safe to say we don't really know?
Well, I would say it's safe to say that we don't have clinical trial data in the BPA population. We certainly know that patients with residual disease after a pulmonary endarterectomy, we reevaluate them, we risk stratify them, and in some cases, we use therapy on them. The currently FDA-approved therapy is riociguat. I think we all try to do the best we can to take care of patients after BPA, and we may translate some data to them from the post-PEA situation, but there's really not an evidence base there to make any firm conclusions.
Okay. Dr. Forfia, your witness.
Thank you. Dr. McLaughlin, what is the current recommended treatment algorithm for residual pulmonary hypertension following pulmonary thromboendarterectomy?
So it's important to risk stratify patients after pulmonary endarterectomy, and if indeed they have persistent pulmonary hypertension after a pulmonary endarterectomy, medical therapy for persistent pulmonary hypertension is indicated.
Thank you. So according to the current international guidelines, there is a place for medical therapy in CTEPH patients with persistent PH after PTE. Is that correct?
That is correct.
Thank you. So you bring up a subgroup analysis from CHEST-1. Was this subgroup analysis powered to make any conclusions?
Certainly not. A subgroup analysis that are done in big clinical trial populations are really exploratory. They're hypothesis generating, and I don't think they're definitive in any way. In fact, the subgroups are sometimes imbalanced in number and imbalanced in the clinical characteristics of the patients.
Thank you. So we've heard a lot of medical speak, statistics, and numbers, but Dr. McLaughlin, you do take care of patients, don't you?
I take care of plenty of patients, yes.
Thank you. So if you had a patient who had had an endarterectomy and they had residual pulmonary hypertension, but let's say their mean pulmonary pressure wasn't over 38, it was 33, and their PVR wasn't more than 420 dyne, it was only 400 dyne, and that patient had residual RV dysfunction, would you treat that patient?
Well, Dr. Forfia, I think this question gets to the heart of that blunted effect that we saw in the post-PEA group in CHEST. They were patients that, much like the patient you described, were less ill than the patients with inoperable disease. They had lower PVRs going in, they had less limitations of their hall walk, and hence, this could have been one of the reasons for the blunted treatment effect. So again, it's hard to make comparisons when the groups are uneven, both in number, fewer patients with post-operative pulmonary hypertension in the CHEST trial, and when they're less ill. We have seen in many trials that less ill patients have a blunted treatment effect. So I think it makes it difficult to translate data in general. But when I have a patient like you described sitting in front of me who still has dyspnea and evidence of pulmonary hypertension, and you particularly made a comment about right ventricular dysfunction after a pulmonary endarterectomy, in my practice I would tend to treat such a patient.
Thank you.
Anything further for this witness?
Judge, I have nothing further.
Thank you, Dr. McLaughlin. You may step down.
No further testimony in this case. Please proceed to the next episode for the closing arguments.